Hello, my name is Benjamin Moats, and I'm the first year HPB Surgery Fellow at Atrium Health. Today, I will be presenting laparoscopic hepatectomy versus microwave ablation for colorectal liver metastases, a retrospective analysis. These are my disclosures. Colorectal cancer is one of the most common causes of cancer and cancer-related death in the Western world, with approximately 150,000 new cases per year and approximately 53,000 deaths in the United States alone. Approximately half of patients will develop liver metastases at some point during their disease course, often presenting a significant challenge to surgical management, although survival has improved dramatically over the last few decades to nearly 60% at 5 years. Classically, the mainstay for surgical management of these lesions was liver resection in addition to systemic chemotherapy. However, more recently, ablation technology, in particular microwave ablation, has shown promise for the management of these lesions with proposed similar efficacy and fewer complications. Presently, a phase 3 randomized controlled trial is actively underway in the Netherlands to identify whether microwave ablation for these lesions, smaller than 3 centimeters, is non-inferior to hepatic resection, but is likely several years away from publication and is limited by the use of a percutaneous approach to ablation. In our institution, we generally favor using laparoscopic ultrasound-guided microwave ablation because it offers the opportunity to identify lesions not visible on other imaging, which occurs in approximately 10 to 15% of cases. It also allows for direct targeting of lesions using visual cues in conjunction with ultrasound guidance. Currently, there are no trials comparing laparoscopic liver resection to laparoscopic ultrasound-guided microwave ablation for colorectal liver metastases. To help answer this question, we performed a retrospective review of our prospectively maintained REDCap registry, which captures all HPB procedures performed in our single regional tertiary care center with a high volume HPB practice. The database was retrospectively queried for all minimally invasive liver resections and laparoscopic ultrasound-guided microwave ablations performed with curative intent for colorectal liver metastases between January 2008 and March 2019. Patients with incomplete follow-up data were excluded. Data was collected, including patient demographics, preoperative characteristics, intraoperative details, and postoperative outcomes. The primary outcome of interest is incomplete treatment, defined as an R1 or R2 resection on final pathology following laparoscopic hepatectomy, or incomplete ablation on postoperative CT following microwave ablation. Secondary outcomes included intraoperative details such as estimated blood loss and postoperative outcomes such as hospital length of stay and 30-day clavien-dendo complications. In total, 252 patients with colorectal liver metastases were treated, of whom 98 underwent MIS hepatectomy and 154 underwent laparoscopic-assisted microwave ablation. There were no significant demographic differences between the two groups. Median age was 59 years in the resection group versus 60 in the microwave ablation group. The median number of tumors treated in both groups was 1, although patients with multiple tumors and maximum tumor size less than 3 centimeters were more likely to undergo microwave ablation, while those with tumors greater than or equal to 3 centimeters were more likely to undergo minimally invasive resection. Intraoperatively, estimated blood loss was higher for MIS resections compared with microwave ablations. For the primary outcome of interest, the rate of incomplete treatment, this was significantly higher at 14.1% in patients undergoing MIS hepatectomy compared to 4.3% in those undergoing microwave ablation. Postoperatively, median length of stay was also significantly longer for the MIS group, at 3.5 days versus 2 days for those who underwent microwave ablation. The rate of 30-day postoperative complications was significantly less likely in the microwave ablation group at 31.7% compared with 38%. with a higher percentage of high-grade complications of grade 3 or higher in the MIS resection group. There was 1 perioperative mortality in the MIS group and none in the microwave ablation group, which was statistically non-significant. So in conclusion, laparoscopic microwave ablation is a safe and effective treatment modality for patients with colorectal liver metastases. Most importantly, patients undergoing laparoscopic microwave ablation had lower rates of incomplete treatment compared with those who underwent MIS hepatectomy. Additionally, microwave ablation was associated with lower operative risk, with less estimated blood loss and fewer postoperative complications, shorter hospital length of stay, and lower rates of incomplete treatment compared to minimally invasive hepatectomy. We believe these findings support the consideration of laparoscopic microwave ablation as a first-line treatment modality for patients with colorectal liver metastases. Thank you for your attention.